Kalispera, good afternoon, and thank you again to Mano and Mano for organizing such a wonderful course once again. It's nice to be back in Athens and to be together in person. So some of my presentation and talk today is going to dovetail nicely on the previous presentation, results and expectations of reverse shoulder arthroplasty for massive irreparable rotator cuff tears. So massive rotator cuff tears can present a clinical challenge to us as shoulder specialists, and what's interesting about them, as we have all seen, is they have a very variable presentation. Some patients have minimal pain, well-compensated shoulders, and obviously these patients don't require significant treatment, but others are severely debilitated, pseudo-paralytic in some cases. Now thankfully, the massive tears that do require surgical repair, most of these are repairable, and much of this prognosis can be gleaned with preoperative imaging, as I will talk about in a little bit. Most irreparable tears are massive, but massive does not necessarily imply irreparability. Next slide, please. So what are some of the radiographic predictors of failure? So we heard earlier about acromial-humeral distance and diminished acromial-humeral distance, and so when this is less than 7 millimeters, it carries a poor prognosis for repair, or furthermore, a high chance of re-tear even after successful technical repair. And certainly MRI evaluation allows us to stage fatty infiltration. As we see here, there's a clear correlation between fatty infiltration of the cuff and clinical outcome, risk of structural failure, following rotator cuff repair, and repairability. So the etiology of progression of fatty infiltration, which we know is not reversible, continues to be debated. It's a little bit unclear. And so there are certainly macroarchitectural factors with retraction of the tendon, changes in pennation angle, which have been suggested to be a factor. Certainly other factors, neurologic factors perhaps with compression or injury to the suprascapular nerve. And obviously diffusible mediators also play a role in the development and progression of fatty infiltration. So when we see an oblique sagittal sequence, as we see here, with advanced fatty infiltration of the supraspinatus and infraspinatus, we know going in that this is likely not repairable. And if a limited Gold's arthroscopy is to be considered more for pain relief, we know that degree of functional improvement is less predictable. So what can we do better arthroscopically to not impact reconstruction later? And the much dreaded tear, as we see here, if we can click on that video, please, is the leading edge of a rotator cuff tear, which despite releases and release of the coracohumeral ligament and other methods is simply not reducible. Now what's interesting, as I mentioned earlier, some patients with identical imaging can have very different presentations. So this patient on the left has a massive retracted tear, irreparable, advanced fatty infiltration, but he's well compensated. In contrast to the right, this patient is pseudo-paralytic. And so this is one of the key factors that will lean me to consider more an arthroplasty option than some of the other arthroscopic options which we have available to us today. So thankfully in 2022 we have many options if we're considering surgical treatment for a massive irreparable rotator cuff tear, debridement, treatment of biceps pathology, other pain generators can lead to improved outcomes in patients to a degree. Partial repair has been shown to be effective to a degree. We heard nice presentations really about tendon transfers, whether they be latissimus, trapezius, etc. Extracellular matrix augmentation continues to be explored. I think it has fallen a little bit out of favor given some of the other developments technologically. Superior capsular reconstruction we heard about earlier, which is described here. And granted, it's very different in the United States, where we tend to use allografts more so than the classic technique of Dr. Mahata using a fascia lata autograft. Subacromial balloon. This is new to the scene in the United States. The subacromial balloon was FDA approved less than a year ago, and so I have some experience with this, but I've been very pleased, at least in the early term, with some of the results. And it's a very easy procedure, obviously. And then finally, reverse shoulder arthroplasty, which will be what I will really focus on today. So we know that the rotator cuff deficient shoulder has force imbalance, superior migration of the humeral head, unstable center of rotation, and pain and poor function. And so the advent of the reverse with a medialized and distalized center of rotation, and certainly the work of Paul Gramont and others, really have revolutionized this and have led to this to be here to stay, time to come. The indications for the reverse are well known to us all, with really rotator cuff tear arthropathy being the most predictable, most durable, and then all the way down to massive irreparable rotator cuff tears. So when is reverse shoulder arthroplasty best for massive irreparable rotator cuff tears? Certainly in the setting of advanced glenohumeral arthritis with significant proximal migration. I have not personally had good success with some of the other methods which were listed below. Patients who have a concomitant subscapularis tear, pseudoparalysis, these are patients for me that I'm leaning more towards reverse arthroplasty. Now, we have Bossum in the audience here, and so certainly his publication has shown that even in the setting of subscapularis tears which are repairable or with pseudoparalysis, with his lower trapezius transfer, he was able to still get good outcomes on that patient population. I'd like to hear more about that at some point. When do we consider reverse arthroplasty? You know, patients who have low activity demands are ideal, and so we would not consider reverse arthroplasty in an elderly patient with a massive irreparable cuff tear who is going to subject that prosthesis to heavy loads. Older patients with less concern for implant longevity or prosthetic failures. And what's the upside of reverse arthroplasty? We can provide predictable pain relief and functional improvement, perhaps more so than some of the other treatments. So in a situation such as this, where we have obvious cuff tear arthropathy, arthrosis, proximal migration, I'm going to look right to reverse arthroplasty in the vast majority of cases as a surgical treatment of choice. Here's a patient of mine early in my career, 2005, who had cuff tear arthropathy, 2 prior failed repairs, proximal migration, arthrosis, and just saw them for follow-up. Nearly almost 20 years following surgery, doing fine, stable implant. You know, certainly the technology has evolved further beyond what was available to us back in 2005, but doing well and still functioning very in a happy fashion. Reverse arthroplasty today, well, we have improved implant designs, better base plate fixation. We have shorter stems or stemless humeral component designs. We have preoperative planning software. We have intraoperative guides, which can help us execute better our surgical plan. And as I talked about yesterday during the lunch hour, augmented reality, mixed reality, new things that are coming down the pipeline to enhance our precision and our execution of surgical plans. The goal with reverse arthroplasty, I would say the number one goal is certainly placement of a stable implant, but preservation of glenoid bone is of paramount importance. And so some of these technological advances can help us minimize over-aggressive reaming and to preserve bone as much as possible. I was a principal investigator recently. We completed in the United States an FDA trial looking at the first stemless reverse arthroplasty. This is with FX shoulder, performing very, very well, and the mid and long-term clinical outcomes are certainly forthcoming. If we can turn on the audio, please. This patient here.
So, Mr. Kemp, I want you to tell us you're now
stemless
6
reverse
weeks
on one
following
side.
a stemless reverse on the left shoulder.
That's correct.
And how are you feeling overall?
I'm great. I mean, I don't know if that's...
How does it compare to the right side where you had a stemless anatomic total shoulder?
It's by far less pain than it was on the right side.
So 6 weeks
and
post-op.
how about your recovery so far if you compare the two sides?
It's been amazing. It's been quicker.
Okay, now on the left side, I want us to measure your range of motion. So elevate your arm up for me.
Oh, wait, like reaching?
Yep. Okay, very good. Now come down, and then I want you to rotate your elbow out to the side. Very good. And if you could stand up and turn to the side and reach behind your back.
Oh boy, it's a tough one.
Turn to the side so I can see how far up your back you can go. And it's still early, but you're still a little tight there. Okay,
And I'm pretty tight all around anyway.
very good.
So anyways, the short answer of that, and the patient to the right, if you can click on that video, this is 1 year post-op, is we are seeing with the less invasive humeral components, patients are recovering more quickly, they're having less post-operative pain. We're doing more and more shoulder arthroplasties as outpatients. So this is really the future. So what does the literature tell us about reverse arthroplasty for irreparable rotator cuff tears? Where this is a nice study done by Mark Frankel and colleagues, retrospective study of patients without glenohumeral arthritis who underwent reverse shoulder arthroplasty. This was published in 2015, Journal of Shoulder and Elbow. And what they found was that Poor outcomes with reverse. We heard this in the earlier talk before myself. Younger patients, aged less than 60, did not perform as well with reverse arthroplasty. Patients who had neurologic dysfunction of some sort and patients who had a higher preoperative functional outcome score did not do as well with reverse. So something to consider in that patient population. Here's another nice study. This is a meta-analysis of 6 studies, 266 shoulders. Patients with massive irreparable rotator cuff tears, again, without glenohumeral arthritis, follow-up of 24 to 61 months. And they concluded that patients with irreparable massive cuff tears without the presence of arthritis had a high likelihood of achieving a painless shoulder and functional improvement after reverse shoulder arthroplasty. This is work from Christian Gerber, retrospective study of 46 shoulders, mean age of 60, and so they wanted to see what were the results that one would expect with reverse arthroplasty in patients less than age 65, with results of 5 to 15 years. I think some of the longest post-op clinical outcome published work comes from Christian Gerber, and so what he found was that there was statistically significant improvement with reverse shoulder arthroplasty. What was remarkable was a very high complication rate, nearly 40%. So higher complication rate with reverse arthroplasty in younger patients, perhaps because of activity demands, so something to think about. Here's a meta-analysis, again, Christian Gerber and colleagues, looking at reverse for massive irreparable cuff tears, 365 shoulders, mean follow-up of nearly 10 years, 5 to 20 years. And they found statistically significant improvements with reverse that was durable up to 20 years post-op. So in conclusion, he said that pooled long-term results of reverse for massive irreparable cuff tears showing significant improvement of overhead function and of objective and subjective outcome scores 20 years after surgery. What about comparing reverse arthroplasty to other options like SCR, superior capsular reconstruction? This is Peter Millett's group looking at a case control series comparing SCR with reverse in patients, again, without arthritis, 22 patients with SCR, 33 patients with reverse arthroplasty. The mean age was slightly younger for patients with SCR, which makes sense. And they found this is early term follow-up, no significant difference between reverse patients and SCR patients at 2 years minimum follow-up. And this kind of outlines their outcomes. So ultimately, this is a very recent publication, 2021. So this is the near circle of the American Shoulder and Elbow Surgeons. So they had 72 expert shoulder surgeons that went through a Delphi process, reviewing all available treatments for massive irreparable rotator cuff tears, debridement, partial repair, SCR, all the things that I mentioned, tendon transfers, and reverse. So they presented 60 clinical scenarios to these 72 experts, and the conclusion following the Delphi process was that there was consensus regarding reverse shoulder as their preferred treatment strategy in older patients with pseudoparalysis, irreparable subscapularis, and dynamic instability. And so that was their conclusion. So to conclude, massive irreparable rotator cuff tears are associated with variable degrees of pain and dysfunction in patients. That's what makes the treatment of rotator cuff disease so interesting. A variety of arthroscopic and open treatments are available to surgeons today that do not include prosthetic reconstruction, and some of these are continuing to evolve, and more data will be collected over time. Some of these treatments are less predictable in the setting of glenohumeral arthritis, pseudoparalysis, which continues to be a matter of debate. How does one define pseudoparalysis? But nonetheless, pseudoparalysis is important to consider. And then subscapularis insufficiency. And so we've seen that the subscapularis is critical when we have massive tears of the posterior superior cuff, and be it tendon transfer, latissimus transfer, and various other studies, the subscapularis is very, very important. So finally, reverse shoulder arthroplasty provides predictable and durable pain relief and functional improvement in these patients, and especially those with arthritis and low demands. Thank you.